Treatment modalities. Once candidates are identified for liposuction, several modalities exist for treatment depending on the following factors. Surgeon preference. Body area to be suctioned. Amount of expected aspirate, and history of previous liposuction. Common modalities include suction-assisted liposuction, SAL. Ultrasound-assisted liposuction, UAL. Vaser-assisted liposuction, VAL. Power-assisted liposuction, PAL. Laser-assisted liposuction, LAL. Water jet-assisted liposuction, WAL. Radiofrequency-assisted liposuction, RFAL. Air sculpt, next-generation body contouring. Suction-assisted liposuction. Suction-assisted liposuction is the workhorse of liposuction. It was the first technique described in liposuction and remains the most commonly used method. Suction-assisted liposuction is a traditional method of liposuction using a blunt small cannula connected to a pressurized vacuum machine. SAL removes adipocytes and other tissues through mechanical avulsion. SAL is performed starting with larger diameter cannula in the deeper plane and transitioning to smaller diameter cannula in the superficial plane. Although SAL can remove the superficial fat, this comes at higher risks to the skin and its blood supply. Bruising and potential of longer recovery are also risks that have to be considered in this technique. The patient is marked standing in the photo suite and in front of a mirror, if possible, preoperatively. Areas to be treated are drawn in a topographical manner, anticipating the feathering of technique at the margins. Areas to be suctioned are marked with a circle, zones of adherence and areas to avoid are marked with hash marks. The patient is placed supine, depending on the areas to be treated. Sequential compression devices are placed on the patient and activated prior to the induction of general anesthesia. Intubation is via endotracheal tube due to the need unless the patient will remain supine, in which a laryngeal mask airway could be appropriate. The patient is properly padded and warmed, tumescent fluid are infiltrated. The modified Hunstad tumescent fluid, warmed lactated ringers plus 25 mg lidocaine and 1000 μg epinephrine, unless the estimated aspiration volume is considered large. If so, we further reduce the lidocaine to 12.5 mg per liter. The volume of fluid infiltrated depends on the tissue characteristics. Lighter, fluffier fat, such as the abdomen, takes up more tumescence as the tissues expand and fill. More dense tissues, such the back, are less distensible and fill more quickly with infiltration fluid. The endpoint is a firm, full, turgid, blanching tissue with a positive fountain sign. Peau d'orange is undesirable due to the superficial nature of this fluid. Instead, infiltration should be into all layers, from the loose areolar plane above the deep muscle fascia to above the superficial fascia, tunneling the cannula throughout. Estimating the aspiration volume. For the plastic surgeon with limited experience, the 60 cubic centimeters TUMI syringe technique can be a helpful method of estimating these volumes. Preoperatively, the surgeon should pinch the excess fat, imagining the size of a TUMI 60 cubic centimeters syringe. Next, the number of syringes needed to equal the fat present should be counted and the volume to remove estimated through calculation. In the early 1980s, standard liposuction was taught with 10 passes of the cannula in a single tunnel followed by cannula repositioning, 10 more passes, and so on. This can leave skip areas and cause a washboard deformity. Now, we approach each area creating many tunnels, each with a single pass of the cannula, pulling it back completely in each pass. We perform all-layer liposuction in most regions, starting at the superficial plane and suctioning downward below the superficial fascia until reaching the deep fascia. Asymmetries are addressed with careful attention to the volumes infused and aspirated. Clinical examination after the procedure endpoint is reached should then be adequate to recognize and treat most asymmetries. Syringe-assisted liposuction with blunt cannulas and single-use syringe is to extract the fat by syringe-generated negative pressure. The syringe technique can be slow and tiring for the surgeon to treat large areas. That is why it is recommended in treating small areas. One of its advantages, it can be done under local anesthetic as a day case or even an outpatient surgery. Power-assisted liposuction. Power-assisted liposuction involves an external power source driving the cannulas, which are variable in size and flexible, in a 2 mm reciprocating motion at rates of 4,000 cycles per minute. Microair's power-assisted liposuction handpiece, the PAL, has been trusted to shorten procedure times and reduce surgeon fatigue. That's why PAL by Microair is the leader in power-assisted liposuction, used by 8 out of 10 plastic surgeons. Advocates of PAL contend that it is best used for large volumes, fibrous areas, and revision liposuction. Surgeons' fatigue and time is decreased during the procedure, thus speeding the rate of fat extraction. Added benefits of PAL include intraoperative pain reduction, less swelling, and faster recovery. Fat harvested is 45% faster compared to suction-assisted liposuction and syringe liposuction. Another advantage of PAL is using the Metanorm self-contained tank and the tubing system that guarantees the sterility. The whole system is latex-free, and the harvested fat is less bloody than the manual liposuction and almost pure yellow color, making it useful for fat transfer. Ultrasonic-assisted lipoplasty. Michele Zocchi in Italy and Ralph Clone in the United States are credited with developing and introducing internal ultrasound-assisted liposuction, UAL. The prototype UAL was a two-stage process that involved first breaking or lysing the fat followed by its suction. It began with use of 4 to 6 mm solid titanium probes, which, in contrast to steel, was better to harness the heat released by converting acoustic to mechanical energy. Electric energy is converted into mechanical energy using piezoelectric or quartz crystals, which is then transmitted and magnified by the probe as high frequency, in excess of 16 kHz, acoustic energy inaudible to the human ear. Sound waves consist of alternating expansion and compression cycles. The compression phase exerts positive pressure in the medium, while expansion results from the negative pressure phase. The compression and rarefaction of the ultrasound waves causing breakage of the fat cells. The ultrasound energy is producing 3 main effects on tissues. Cavitation, by implosion of pericellular gas microbubbles. Thermal effect due to friction and parasite absorption trough tissues. Hammer-jack effect due to the direct impact of the tip of the probe proportionally to the wavelength. Since this method generates a lot of heat, there should be plenty of wetting solution to aid dispersion and limit any negative thermal effects. The technological endpoint varies from SAL in that it is not simply the traditional pinch test, but lack of resistance to probe progression that suggests adipocyte liquefaction and the end point. Lipoaspirate is also homogeneous and macroscopically acellular, with a slightly higher level of the intracellular glycerol 3-phosphate dehydrogenase isozyme unique to adipocytes. American doctors accepted UAL, leading to the creation of second-generation UAL devices with hollow cannulae for simultaneous aspiration. Unfortunately, the wetting solution's simultaneous cooling effect is lost, which led to the appearance of third-generation machines, the Vaser. Advantages: less surgeon fatigue. Improved results in fibrous areas and in secondary procedures. Disadvantages: larger incisions, longer operative times, and the possibility of thermal injury. All the complications are strictly related to the operator and not to the technique, and can be easily avoided and/or solved with the appropriate training. Skin burn due to excessive energy and torque of the cannula is showed at 5a, 10b, 120c, and 180d days after surgery. Ultrasound energy applied to liposuction is useful when treating tissues that are extremely fibrous and for secondary procedures. Backs and male abdomens and breasts are all good examples of excellent times to use this technique. As delivery of the energy is most effective in a fluid environment, we prefer to deliver ultrasonic energy to achieve emulsification without aspiration. This is clinically determined by the loss of resistance to cannula passage. Post-emulsification evacuation is then performed using power-assisted liposuction (PAL/SAL) techniques. Care should be taken to treat each side symmetrically and to avoid end hits in the skin.